آقای هاشمیان تشریف دارین؟
این چیه که سلام جناب استاد.
سلام آقای هاشمیان، خوبشون؟
متشکرم استاد، صدای شما خوب میاد.
بله.
من فکر میکنم استاد سخنران اول رو دکتر خوزگل باشن که سخنرانشون ضبط شدن. سخنرانی دوم بعد از سخنرانی خود دکتر گل یک همونجوری که شما فرمودید 10 دقیقه در واقع دیسکاشن باشه و بعد سخنرانی پروفسور روتمن باشه، من 20 دقیقه که بعدش 10 دقیقه دیسکاشن باشه و بعدش پروفسور دعا اگر شما استاد سلام.
بله خوبه، آره اینجور خوبه.
متشکرم استاد.
میخواین دکتر گوئلا شما معرفی کنید؟
بله استاد. دکتر خداپرستم که از طرف دانشگاه یک جلسه‌ای رفتن رامسر، به من گفتن که اینجا اصلا اینترنت ظاهرا درست نداشتن، نتونستن بیان. دکتر گوئلم که خودشون آنلاین هستن.
خب پس اونم شما من نمیشناسن، یه معرفی کوچیکی ازش بکنیم. دکتر هست اون هستش. خب پس هیچ مشکلی نیست. دکتر دیگه هنوز که اونا نیومدن ظاهرا.
من اصلا بهشون ایمیل زدم که دکتر روتمن هم تشریف آوردن.
بله. دکتر
دعا هم که پیغام دادن که میان سر ساعت. من فقط الانم بهشون ایمیل زدم استاد.
دکتر گوئلا هم تشریف آورده. دکتر گوئلا اومدن. اگه میکروفونش رو فعال کنین بگین که hello Dr. Guel, welcome. Can you unmute your mic please?
Hello, how are you?
Hello Dr. Guel, thank you very much. Very welcome.
Oh, thank you very much for inviting me.
Thank you very much. Thank you.
Welcome, Professor Guel, to our webinar. We are very honored to have you here, and we are waiting to hear your keynote lecture. I think we should wait a couple of minutes, 2 minutes, I think, and then we can start. Welcome, Professor.
Okay, that's perfect. Okay,
thank you.
It's late afternoon in Tehran, isn't it?
Yes, it's 6 p.m. in Tehran. I think we have Professor Rootman from Canada. Professor Rootman, can you unmute yourself?
Hi. Hello. Good afternoon. Nice.
Hi, Professor Rootman.
Hi. Nice
very nice.
Hello, David. Nice to see you.
Hi. How are you? How are you, Jose?
I'm doing well.
Welcome, Professor Rootman. We are going to begin in 2 minutes. I should introduce Professor Qureshi to you, head of Iranian Society of Cataract and Refractive Surgery. Welcome, Professor Qureshi.
Dr. Hashemian is a colleague. He is associate professor of ophthalmology at Farabi Hospital, Tehran University of Medical Science, and actually he has arranged this meeting, and this meeting is held by Farabi Hospital. Farabi Hospital is a very important hospital in Tehran. It is a tertiary referral hospital, and it is affiliated to Tehran University of Medical Science, and Dr. Hashemian is a very active
thank you, Professor
of the hospital, and I am from Isfahan University of Medical Science.
And Professor Dua, we have Professor Dua here.
Okay, I think he has. Is he here? Yes, Harminder, can you unmute your microphone, Professor Dua? Okay.
Oh, make him a co-host virtually. That's right.
Hello.
Hello, how are you?
Hello, good afternoon. Good evening.
afternoon. Okay, good.
Good. Welcome, Professor Dua. If you want to, we will be happy to have your video and so we can see you.
Yes,
If it's possible, of course.
It's possible.
it is saying that the host has blocked the video.
Okay, the host has to unlock. Please unlock his video.
Yeah, it is saying the host is not. Now.
Oh,
Yes,
it's okay. Okay, hello, Amanda.
We have met Professor Dua in Tehran before. Very nice to meet you again, Professor Dua.
Thank you.
Hi, Harminder. Very nice to
Hi, Jose. How are you?
Hello.
Good.
اولیش حاضره. I think we can start, Professor Varish, can we start?
Oh, yes, can start, yes. Please.
Okay.
I think the first speaker is...
Professor Jose Guel.
Okay, go ahead.
It's my honor to introduce Professor Jose Guel. I just introduce him in brief. Professor Guel is a professor of ophthalmology in University of Barcelona. He is director of cornea and refractive surgery unit at the Institute of Ocular Microsurgery in Barcelona. And he's the scientific director of the European School of Advanced Studies in Ophthalmology. He has more than 1,000 international talks in different meetings and published more than 300 articles and several book chapters. I just mentioned in brief, and Professor Guel has pre-recorded his lecture, and we are going to see his keynote lecture. I just yes, the lecture of Professor Guel is on DMEC after corneal transplantation. We are just listening to Professor Guel's lecture. Thank you.
Hello. This is a real honor and a pleasure to have been invited by the Iranian Society of Ophthalmology to participate in your meeting. I would be delighted to be in Tehran personally, and really hope to come in the near future, but during this summer is completely impossible for me. But anyway, thanks very much for your kind invitation. I will focus my talk on my experience, or our experience, in doing the MEC after keratoplasty, after different keratoplasty techniques. I have no financial disclosures to deal with this talk. And basically, with small differences between series in different areas of the world, US, UK, Australia, EU, and Asia, and in different periods of the last 20 years, The three main indications for keratoplasty, as you know, are keratoconus, Fuchs endothelial dystrophy, and reintervention. On the other hand, lamellar surgery, we have observed a clear and important trend, although highly asymmetric in relation to the area, of anterior lamellar surgery for advanced keratoconus and other indications. And endothelial transplant techniques have symmetrically replaced worldwide in a relatively short period of time full thickness techniques in the management of Fuchs endothelial dystrophy and other endothelial disorders. We also know that 85% of the reinterventions after penetrating keratoplasty are due to chronic endothelial failure, associated or not to previous rejection episodes. And also that although during the immediate post-op period, rebubbling is the most frequent indication for reintervention after endothelial techniques, during the midterm and long post-operative period, 95% of them are also because of chronic endothelial cell failure. So chronic endothelial cell failure is a keystone in the management of endothelial diseases. It's the commonest cause for reintervention after full-thickness corneal transplant. Obviously, together with a higher risk of immunological rejection, a new full-thickness technique after a previous one is associated with its classical comorbidities, the ones associated with an open sky technique, the unstable and unpredictable astigmatism after the surgery, and a slow visual recovery. On the other hand, EK techniques have the theoretical advantage of a lower risk of immunological rejection, a lower perioperative risk, safer in the presence of ocular surface disease, and a low surgically induced astigmatism with a quicker visual recovery. These two graphs basically highlight the survival rate of consecutive full-thickness transplantations, which drops down to more or less 1 year after 4th or the 5th transplantation. So that's why consider an endothelial technique, endothelial keratoplasty technique, it's much wiser. In fact, if we review the literature, and since the first publications around 2013, this publication from Anshu and Price, and some others later, you can see that the use of both the SAIC and the MEC are getting progressively better results than those observed doing a repeat full-thickness transplantation. That's the same in this very nice comparative article of 2014 from Ang, Mehta, and Tan, where they clearly demonstrate that the graft survival outcomes were obviously better with EK than with repeat full-thickness transplantation. In fact, there is a very nice publication of the last 2 years in PLOS ONE, where we do not also observe a quicker visual rehabilitation, a much better refractive result, but also a 43% lower risk of rejection after endothelial keratoplasty. So in general, looking to what has been published, EK outcomes after PK are generally worse than in primary EK with similar rejection and failure rates for both the SEC and the MEC. Higher rebubbling rates for the MEC, and an average ECD depletion at 6 months after surgery between 25 and 52% in both groups, which is not much higher than after a standard EK, but slightly higher. There is still a debate, as it is also in standard EK cases, between using one or another technique in front of eyes with previous filtering glaucoma surgery, pars plana vitrectomy, poor visualization, extensive synechia, large iris defects, shallow anterior chamber, or aphakia. So in those situations, there are some surgeons that prefer to work with a, let's say, thicker lenticle, as in ultra thin or a standard DESAEC, than with the MEC. And some others, as me, that generally speaking prefers to use the MEC. I just will highlight the results of our original study evaluating retrospectively our experience using the MEC in 26 eyes with previous full thickness keratoplasty and late endothelial failure. One of them had 2 failed PKs previously. 12 eyes, so almost half of them, with a previous history of 1 or more episodes of graft rejection. The other half, no history. That does not mean, obviously, that perhaps it was subclinical, but anyway, no history. Originally, 7 eyes with keratoconus, pseudophakic bullous keratopathy in 11, aphakic bullous keratopathy in 1 eye, and post-infectious keratitis scar 4 eyes, 1 eye with Fuchs dystrophy, and 2 eyes with a post-traumatic corneal wound. So a quite variety of original indications for full thickness. The technique that we used was the one that we already published back in 2013, a bimanual infusion technique with a 7 to 8 millimeters graft diameter. This is obviously adjusted to every single patient. Inferior peripheral iridectomy, 20% SF6 tamponade, but in this particular group, without host descemetorrhexis, because in those, we had no cases with significant posterior fibrosis. That's why we decided in this study group not to do any descemetorrhexis to avoid posterior bone trauma. So this was the original technique. As I mentioned, we used to debride the loose epithelium. Sometimes there are only some areas with loose epithelium and some others that not. We create a 20 gauge paracentesis on the right and a 23 paracentesis for the infusion cannula on the left. We use the standard cataract incision to inject the DMEC lenticle. We use our own injector from Medicel. We position with these tap techniques, as has been described extensively by many other authors. We open it, sometimes with intraocular irrigation, and once it's properly positioned, I would say that in these cases are perhaps more important a proper centration. We introduce our tamponade, 20% SF6. We like to leave the eye medium hard, and we inject cefuroxime through our paracentesis, and this is the end of the procedure. This was our published results, so you can access to the publication. And as you can see, and as expected, there is a clear stability of the spherical equivalent. This is one of the main advantages of doing a EK procedure after full thickness compared with another full thickness case. Visual acuity significantly improved over the following 24 months. And as mentioned, the corneal endothelium density decay is slightly superior, but quite similar to a standard EK. From a complications point of view, in this particular group of patients, we had no episodes of immunological graft rejection as long as it was published, but later on, we had one case of the 18, but it was after the article was published. We had, that's the vignette that you can see on the left, one case that required intracameral air injection, but could you see the folds down there? In order to release this tension, we went to the YAG laser, and with a single shot, we were able to open this let's say, bubble between the stroma and the decimet, break decimet, and then with the gas in the anterior chamber, the decimet applied over the stroma perfectly well. And another, I had an artisan aphakic IOL implantation to correct the residual refractive error. Another, a sulcoflex explantation. This is the vignette that you can see on the right, which is was an eye that had a sulcoflex implanted during the post full thickness period to adjust the refraction, but after the DMEC, this sulcoflex got opacified, and we needed to remove it later on. Well, a couple of other cases. On the left, a 58-year-old male with a previous full thickness transplantation in both eyes for keratoconus in the 90s, then ICL implantation, then another full thickness transplantation with clear lens extraction and IOL exchange. But again, opacification because of chronic endothelial deficiency, and then we do a DMEC. This was one of the first cases that we did. It's a quite old video where we were using the originally described techniques by us. So applying air in front of the decimet to have the decimet lying on the iris surface, and then we took this air out and then introduced air underneath the membrane to apply it over the stroma. On the right eye is a 49-year-old woman with a full thickness transplantation for central scar after contact lens related infectious keratitis, and again secondary low endothelial cell count, and we perform a DMEC to solve the problem. So obviously, since then, many cases have been performed in our institution and in many other institutions worldwide as a rescue technique for chronic endothelial cell loss. The actual technique is not to leave the decimet of the host intact, but instead of that, we do a central decimatorexis. And I mean a central decimatorexis because it needs to be sized smaller than the previous full thickness transplant. Because what we need to be obsessed is in doing the rexis, do not disturb the posterior wound of the full thickness transplantation. So as you can see in the video, we perform during these last years, we are not leaving decimet, but just removing central decimet, because we think, although we have not yet retrospectively evaluate this point, but we think that with a similar rebubbling rate, we will get a slightly superior visual results if we remove decimet. This is obvious in those cases where there is a fibrotic central area, but also in those cases where there is not, removing decimet probably will give us better visual outcomes. But well, still needs to be demonstrated. Anyway, this is the technique that we are using today, despite that in the literature you can see that there are no differences between removing decimet or without removing decimet. Of course, this technique, the MEC, is our favorite also to rescue failed DMECs, because as I mentioned, although the rate probably will be lower, but the main reason to have an endothelial transplantation long-term failure is because of chronic endothelial cell loss. So we will also be able to do a DMEC afterwards. And this has been extensively reviewed by our group in this and published in this article, which is basically our experience in doing the MEC after the MEC for different indications, but the most common, of course, are not the early post-op complications, that there are some, and in some cases we have needed to, as the one that you can see on the video, on the lower video on the right side, which is a impossibility of attach this lenticle despite of several attempts of rebubbling. So we remove this lenticle, introduce another one. There has been a couple of cases that we have needed to operate because of a reverse positioning of the previous membrane. But in most circumstances, we have needed to repeat the MEC because of this chronic endothelial cell loss. The technique is obviously the same. The only main advantage is that in most cases, we do not need to, let's say, remove too many remnants of the posterior stromal surface, and that we already have a patent inferior iridectomy. So there are a couple of steps that we can escape from. Obviously, here, if you take a look to this article, you will see also a review of the outcomes of secondary corneal endothelial allografts worldwide. And in the right one, in this recently published article, you will be able to see also our experience in using secondary MEC after failed dissect in complex eyes. So this is as mentioned, our favorite technique also when the SAG fails, instead of repeating a DSAG, to do a DMEC. This is one of those cases where, because of, again, chronic loss, we replace a previously properly functioning DSAG graft by a DMEC graft. You will see here that sometimes the removing of the previous DSAG graft is not as simple, because it's very well attached with a significant peripheral fibrosis. But anyway, using the adequate forceps, we can remove this lenticle independently of the fibrosis, and then from that moment, the rest of the procedure is as usual. We will inject the MEC lenticle, and we will apply. And again, centering, as we mentioned, after full thickness transplantation is an issue. You really want to have the MEC lenticle properly centered in the area where the SAG lenticle, because you have a kind of shadow or print in your posterior stroma with a knee that you want to escape from. So a proper centering is critical, and also in this setting. This is basically the clinical evolution. Just a last slide saying that the MEC might be also useful in failed DALC, previous DALC. You don't need to consider a full thickness transplantation, but it is much logical to consider a DMEC. Failures, chronic endothelial failures after DALC obviously are much less important than after full thickness transplantation, but it still is an issue, especially in the long term, and DMEC will be a nice possibility. So in summary, EK has become worldwide the favorite surgical approach for failed PK, with a significant lower associated risk ratio and much quicker visual rehabilitation time than the new full thickness. Compare long-term EC survival is still lacking, although the ones that has been published up to now looks like a better behavior of these lamellar grafts than a new full thickness graft. The MEC is also my favorite surgical approach for EK in this setting. Obviously, a greater amount of surgical difficulties and complications should be expected in this group of eyes. You can decide to do a no rhexis or a central rhexis. Still today, no significant difference in published work. Despite my own preferences, it looks like neither graft sizing nor stripping have a major impact on detachment rates in both the SAEC and the MEC, as I mentioned. And as I also mentioned, the MEC is also probably the best option for failed SEC and the MEC, although we will need to take into account in these repeated cases the role of densitometry, because perhaps in some cases, if we want to achieve the highest visual results, perhaps in some cases we will need to consider to replace also the stroma. Thanks very much for your kind attention.
Thank you for. Thank you, Professor Guel, for very nice and instructive presentation. I have only one question. Here, in most cases, we prepare DMEC lenticles in the operating room. How do you get DMEC lenticles? Do you have them from? Do you get them from the eye bank, or you prepare it by yourself? And tell us about the reoperation rate and rebubbling rate compared to ultra thin DZEC or nano thin DZEC. Thank you, sir. And I want to ask your audience if they have any question, just write down in the chat box. We have a 10-minute discussion about the presentation of Professor Guel, and after that we go on with complications of DMEC by Professor Rootman. Thank you, Professor Guel.
Well, Farabi.
Please unmute.
No, could you hear me?
Please unmute.
Yes,
unmute
yes.
yourself.
We can hear. Yes.
I have it on mute. Could you hear me now?
I can hear you. I don't know.
Yes. Okay, I can hear you.
Okay, perfect. Well, again, thanks very much for your kind invitation. And regarding your both questions, well, of course, for as possibly in most clinics worldwide, during the next 5-10 years, we were preparing ourselves the lenticles. And in fact, I am still doing today sometimes, because the speed of providing me tissue prepared by the eye bank sometimes is not as good as the one that I want. But anyway, now many eye banks, including the one in Barcelona, are usually, if you ask for the MEC lenticle, they prepare it, and then they send the lenticle pre-prepared, as you have seen. The only limitation when we were preparing ourselves a lenticle, it was beside the fact that you needed 10 minutes more of surgery, which is not a big deal, that sometimes at least one every 20 or 25, you had a lenticle loss, because preparing it, you have a tear. And so the main advantage of having the eye bank providing to you the tissue already prepared is that you will escape from that. Regarding rebubbling, of course, it's absolutely well known that rebubbling is higher in most series, if not all series, for the MEC compared with ultra thin DZEC or the technique which was described by Harminder, which is a PDMEC, which includes in the dissection not only decimate and endothelial, but also Duas layer, which basically ends up with a slightly thicker lenticle, easier to be manipulated in the anterior chamber. From my point of view, if you improve your technique, the rate of rebubbling can go down up to about 10%, which is the mean that I have today. So still higher than the ones that you have with other techniques, such as ultrathin or the SAIC. But I think that the advantages of this technique in front of the SAIC are superior, and that's why I prefer to still using the MEC. And the problem with ultrathin, the SAIC, and at least in my experience with PEDMEC, is that the preparation of the lenticle is, at least in my hands, not as easy. So to have really an ultra thin lenticle of about 80 microns in a constant manner, or to obtain this dissection that Harminder showed us so easily, at least in my hands, are not as easy as to obtain a pure the MEC lenticle. And that's why I still think that unless the preparation technique improves significantly, in my hands, it will be easy to continue with the MEC.
Thank you, Professor Goel. Professor Qureshi, do you have any questions?
Yes. Actually, there are a lot of questions, but I am not sure that we can answer all of them, because it is a very interesting subject, and the talk was very excellent. Thank you very much, Dr. Goel, for this very nice talk. I didn't understand, your cases were phakic or pseudophakic or aphakic, most of them. And how do you manage cataract? Do you do combined operation in all cases, or you do DMEC only in some cases of cataract? And there are some challenges that I will ask you after this question. Please answer this question, and later on I ask you other questions.
Well, the decision of performing in a phakic eye cataract surgery at the time of the MEC is unrelated, from my point of view, with the MEC itself. Is related with what I want to do with the crystalline lens. So let me. There are two clear examples. So if you have a cataract that is affecting vision, of course, and you have an endothelial disease, you will do a combined procedure, because it makes no sense to divide both. The results with the combined technique for most of us are regarding the survival of the lenticle and the rebubbling rate are quite similar, with combined and with isolated the MEC. So if you have a cataract, you will do a combined procedure. The point is that if you do not have a cataract, and taking into account that the surgery itself and the topical steroid treatment post-op will in the, let's say, middle-aged people, will increase the opacity during the following months after the lamellar surgery, especially in the hyperopic group, you might consider to do combined surgery, despite there is not yet a cataract. So a clear example, I don't know, 58 years old, 3+ diopters hyperopic patient. So, and with Fuchs dystrophy, I probably would propose to my patient to do a combined surgery, because I can do both refractive cataract and the MEC. The only point would be that sometimes you will need to deal, not as much, of course, as with the SAIC, with a undetermined final refractive outcome. So from that point of view, if the cornea is extremely edematous, you might consider to do first the MEC and leave cataract surgery as a second step surgery later on, in order to have a better biometric calculation. But But well, I think that that's what you asked.
Okay, thank you very much. Because I meant mostly on the clear lenses, the patient that had clear lens, and you answered very well. And I am sure that there are challenges with DMAC in post-PK. One is the wound leak. Usually you have to manage wound leak in these cases. Other challenge is that some of these cases have a very irregular cornea. The anterior cornea is very irregular, or maybe there are high cylinders. So how do you deal with these cases? Do you recommend addressing the irregularity of the cornea before doing DMAC, or you go first do DMAC and then after do the treatment on the cornea? Because especially if the patient is post keratoconus, usually this cornea or when they are failed, they develop a lot of irregularities and maybe high cylinders. So how do you deal with this problem?
This is a very, very good question. Let me tell you, Mohammed, what if you are in front of a, let's say, late failure keratoconus case who had full thickness keratoplasty, in this case, you do not only have a opaque cornea because of a chronic endothelial failure, but also a kind of recurrence of the previous keratoconus with a high irregularity. Personally, I would possibly consider to repeat a full thickness, because except if this patient, for example, would be before the endothelial failure, he was or she was a good rigid gas permeable contact lens wearer. So, but I understand your point. You might have two issues, and you would, as always, we as surgeons would need to decide preoperatively which is the best approach to deal with these two issues. So if I have a significant irregularity, which is not due because of the failure of the endothelium, because sometimes this irregularity is because this irregular epithelium, but is an irregularity secondary, as I mentioned, to a recurrence of the keratoconus or whatever other reason. If I do not think that I will be able to solve this irregularity afterwards, after my DMAC, I think that I would consider to do another full thing.
Okay, thank you very much. I think there are some more questions, but I am not sure if we have more time. I think we have proceed with other speaker, and at the end, if we have time, we will also answer more questions. And I personally think that if you can manage both the irregularity and the endothelium, if the cornea is viable, for example, is not very ectatic, you can manage the irregularity and the high cylinder before DMAC or after DMAC. So you can, preserve the previous cornea. That would be good if you can do both techniques together, or maybe separate or sequential. Thank you very much. Okay, can you announce next speaker, Dr. Hashemian?
Thank you, Professor Qureshi, for the nice discussion, and thanks, Professor Goel, for interesting keynote speech. I was very interested to read about history of Professor David Ruthman, and I'm honored to introduce him. He's a board member of Cornea Society at Toronto University. He performs over 150 cornea transplantation, and most of them are complicated, difficult cases annually. He's the first Canadian surgeon to perform deep lamellar endothelial keratoplasty, femtosecond laser-enabled keratoplasty, femtosecond AK, and intercorneal ring segments for keratoconus. I think almost all interesting surgeries, he was a pioneer in Canada. He has trained many cornea surgeons over 10 different countries, and he has been director of the Eye Bank of Canada for more than 10 years. Thank you, Professor Ruthman, for joining us, and we are waiting to listen to your keynote lecture about complications of DMEC. Thank you.
Thank you very much for that kind introduction, and it's great to be here with you. I wish it was in person, and I hope to visit your beautiful country someday. So let me just find my. This is not pre-recorded, so it's not going to be as polished and beautiful as Jose's talk, but I'll do my best to follow up from Dr. Guel, who gave us such a nice talk just previously. In the short period of time that's allotted, it's really not possible to cover all of the complications of DMEC, but I'll do my best to show you some interesting complications that have occurred over the years. I think that EK, thanks to Gerrit Mellis, who has really added so much interest and so much controversy to our corneal practices over the past 20 years. And must say things were getting a little bit redundant and boring with just penetrating grafts. And then all of a sudden, there was this explosion of lamellar technology that has really gave a great boost to my career. And I'm sure the many in the audience feel the same way. So what I'm going to do is just talk about some of the complications that occur all the way from tissue preparation to post-operatively. And we prepare all of our own tissue generally. We can get pre-stripped and preloaded tissue if we want it, but personally, I think if you're in a training situation, I think it's much better for your fellows to get the feel for what Descemet's membrane is like and the attachment to the stroma, because you never know. First of all, I think it makes them better surgeons, and second of all, you never know when you're going to have to prepare tissue on your own if you're down to your last case and all you've got is a PK tissue and you ruin the tissue, or there's some mishap with it, you may have to do it yourself. So I'm just going to go over a couple of scenarios here. You can see this is we're trying to strip the tissue, and peripheral tears are starting to develop. There's one that's occurred there, and if we watch further on in the video, sometimes these peripheral tears occur, and they can either be in the form of a radial tear, or sometimes you can get a horseshoe tear, such as this one here. And the simple solution for this is to either move to a different zone to try and strip down into the 8.0 millimeter zone. And then you can do a rescue procedure is here. But when you're first stripping the tissue, if you do get one of those horseshoe tears or a radial tear, you can sometimes just use the broad end of your fine tying forceps to grasp across the tear and then continue it on. You can see that this one, it's not the most beautiful tissue preparation in the world. It's got some little tears and notches out of the edge, but the endothelium has probably been minimally damaged, and this patient ended up doing quite well. This was another case that early on in my experience, and the peripheral endothelium and Descemet's membrane has been stripped. And then when removing the skirt, I wasn't quite right through Descemet's membrane over in this area here. If you follow and watch what happens as I strip off the peripheral tissue, there's a cut right across the cornea. And while it's sad that we lost probably about 5% or less of the tissue, and nonetheless, this is still quite an adequate graft that will be able to fix the endothelial problem of the patient. So with preparation tears, small ones are okay. You can usually work around them. If you have a larger tear, sometimes you can decenter your trephination to exclude it from your graft, because it's always easier and safer if you've got a continuously round cut. But if not, you can do what I call is a tree fine and rescue. You tree fine down, as long as you've got one area that is beyond your trephine mark. So if you're using an 8mm tree fine, if you can strip within that 8mm zone, then it's really quite straightforward to rescue it, and you can peel off almost like capsulorhexis in a circular fashion, and trying to avoid the areas of the tear. And of course, if possible, it's always good to have backup tissue in case you do have to discard the tissue. Now we'll go on to intraoperative complications, and this was a gentleman that I operated on quite early in my experience, and just observe what happens, and then we'll briefly discuss what the problem was that created this issue. So you can see I'm getting ready to insert the graft into the eye. I open up the incision, and boom, the pressure from inside the eye has washed the donor out of my injector, and now I'm going to reinsert it. And the issue is that I erroneously went in with the bevel up of my injector. So always when you go to do these, the injection part of the procedure, you have to be certain that the bevel is down, and also that the pressure inside the eye is not so high that if you do distract the wound with your 0.12 forceps, that you don't get a sudden efflux of fluid that can then wash your tissue out of the injector. And this is quite ironically the same patient, but occasionally, if you're not careful with your tapping and injecting, the donor can end up going behind the pupil, and usually it's fairly straightforward to bring it out by injecting underneath it and gently teasing it up into the anterior chamber. And this patient has done well. His endothelial cell count was, of course, reduced due to the extra manipulation, but he's maintained a clear graft for quite some time. Now, this was a patient that came, this was her only eye, and I was doing a combined procedure. I had already done the cataract surgery, and watch where I place the injector. I'm just going barely inside the incision, and often the pupil doesn't come down very well with the myocol, and in this case, it actually, the graft was injected and went behind the intraocular lens. And this is her only eye, and I don't know if I had an extra tissue at the time, but I tried various irrigation techniques, going behind the pupil, going behind the lens, and I'm just going to move it along here for the sake of time. But eventually, I was able to exteriorize into the anterior chamber just a small bit of the DMEC membrane, and it's right there. And then I was able to get it to come up into the anterior chamber, and then I used the capsulorhexis forceps to grasp the edge of the donor and bring it up into the anterior chamber. And finally, you can see that I was able to get the graft back into the anterior chamber, And with irrigation and tapping, the graft unfolded quite nicely. And the patient brought me a beautiful gift about 2 weeks after the surgery. I don't think she quite understood the trials and travails of getting this DMEC graft to be in the correct position. Now, these are difficult cases. This patient had a retinal detachment repaired and had a vitrectomy as well, and his cornea then later failed. And I put in a posterior infusion, but at this point the infusion was turned off because I'm trying to manipulate the graft. And you can see I'm doing the usual flushing maneuvers, and then all of a sudden the graft disappears. So let's just look in slow motion to see what actually happened. Graft is, it looks like, well, we're in the clear here now, but then I do one firm tap on the eye and the graft has gone into the vitreous cavity. You can see it floating behind there. I was unable to retrieve it at this procedure, and I went back a week later with our retina surgeon. He put in a second trocar and the graft immediately was flushed out of the eye. I had a second graft prepared, and I was able to complete the case. And I think the teaching point to remember about these cases post-vitrectomy is that it's very easy for the eye to become excessively soft. Especially here, I had turned off the infusion as I was preparing to unfold the graft. So what happens is the eye gets softer and softer. The scleral wall collapses inward until it reaches its point of elasticity, where the eye suddenly expands. So that can suck your donor. It creates negative pressure in the vitreous cavity and can suck the donor right from the anterior chamber behind an intraocular lens and into the posterior vitreous cavity. So it's important to be mindful of that if you're going to do these vitrectomy cases. I formerly would almost always use a posterior infusion, but when we look back on our data, we found that there was a higher rate of retinal detachment.
Excuse me, is your screen frozen? Because I cannot.
No, it wasn't. I was just giving
Okay.
a little bit more commentary on that case.
Okay.
They're not frozen yet, anyhow.
Okay. Good.
So you can either use the posterior infusion, as I said, but there is a higher rate of detachment, and there are ways to get around it. The patients that have had vitrectomy and still be able to do a DMEC rather than a DSEC. So when I took the course many years ago with Harriet Mellis, he wasn't marking the grafts, and I don't think he does anymore I don't think he does even still, because of the chance of damaging the endothelium. And I think most people, at least in North America, like to put a mark. I was using the F mark. Now we use a line and a single dot to try and minimize the amount of marking on the stromal side of Descemet's membrane. And what Harriet Mellis described is that the endothelium is always on the outside of the graft, and if the graft is going like this, if it's fluttering towards the cornea, then you know it's in the right orientation. And here's just an illustration of this is my fellow doing the case. I think she's doing a really good job. It looks like this edge of the graft is fluttering towards the surface, the back surface of the cornea. So I think that we're okay. And she's centering it and now opening it up. But if you look here, I'll just show you in a moment, but after we put the air bubble in, the F is in the opposite orientation, telling us that the graft is upside down. It's right here. And see, we're using the pointer to point it out, and there. So that's the way the F mark turned out. So I asked my fellow to stand aside, and I tried it a second time, and you can see it looks like it's in the correct orientation, and yet the F once again is upside down. So it took us until a third go at it, and then now you can see the F mark here is in the correct orientation. So for my first 50 or so DMECs, I did not put a mark on the Decimase membrane, and I had a couple primary failures in cases that I thought went really well, like just very straightforward cases with guttata and not much edema. And looking back on it, I think it was because some of these cases may have been inadvertently placed with the endothelium against the stroma rather than facing the iris. So that's why I continue to mark, and I think it is important to try and reduce your complication rate. So post-operatively, one of the bugaboos of DMEC surgery and corneal transplant surgery in general is primary failure. And this can be due to multiple causes. Some are due to eye bank preparation, or they can be due to your own tissue preparation, orientation, and of course, excessive manipulation, particularly in the complicated cases. And post-operatively, we can use the anterior segment OCT and rebubble. And in some cases, you have to regraft. And I warn my patients, I tell them that there's probably a chance of about 5% that they'll have to have a second procedure. Occasionally we get a pupillary block. Our routine is not to do a peripheral iridectomy. I did it on the first several cases that I did. And I found that it was sometimes difficult because you would get some bleeding, and that can interfere with your unfolding of the graft. And really, I've found that most of the time it isn't necessary if you dilate the patient well at the end of the case and then look at them 2 hours post-operatively. Here's a patient at the 2-hour post-operative visit, and there's some shallowing and probably some iris corneal touch down below. And this is easy to remedy by burping some of the air out from the bubble. And of course, if you do an inferior PI, the chance of this occurring is even less. But we've had very little problems with pupillary block if we do our usual routine of looking at the patient about 2 hours after the surgery is completed. So for treatment, you can burp the paracentesis. If there's actually air behind the iris, then dilating the pupil well and having the patient lie on their back usually will remedy the problem. Occasionally we get peripheral detachments. They're fairly common. You can see on this slit lamp examination, there's a small inferior detachment. And on OCT examination, if you get the scroll looking like this, then you know that it's in the correct orientation. So that's representing the curling towards the corneal stroma, and then you can be reassured that at least the donor's in the correct orientation. If it's small and peripheral, often I'll leave these alone. And obviously, if it's closer to the center and affecting the vision, then we'll go ahead and rebubble. And I think rejection is a very important occurrence. I think this is one of the most attractive ideas related to DMEC surgery, is that our rejection rate is so much lower, at least in the routine cases. And this was from a large series that we did. We never published it, but in our large series of graphs, Our rejection rate with penetrating keratoplasties was around 12%. With DSEC, it went down to about 8%. And with DMEC, at least in the routine cases, the rejection rate has been very comparable to what we find in the literature of being 1% or less. And the studies have shown that keeping patients on steroid drops can help prevent endothelial rejection. And it sometimes appears a little bit differently. We don't get a coup-de-douce line in general like you do with a penetrating graft. You can see the area of the edema is everything down and to the left of this line. And whereas with the endothelial rejection with DMEC, often you get a more diffuse edema with just a few kP and not that distinct line that you'll see with the penetrating graft. The treatment, however, is the same, and often we've been successful at reversing the rejection in these cases. In terms of endothelial cell loss, one of our first series actually showed that our endothelial cell loss was less with DMEC compared to DSEC surgery. And that was surprising to us, but nonetheless, that our data showed that. There are some suggestions that there's more endothelial cell loss with DMEC, and we can try and minimize the trauma to the tissue. And also when you're preparing the tissue in the operating room, you can put vision blue on and assess on the spot whether the endothelium is sufficient to proceed with the surgery. And this was one of our earlier cases. You can see at 2 months post-operatively, the cell count is almost 2,800 cells, and the architecture looks fairly normal. So these are some of the reasons why I love DMEC. I'll let you read them for yourself afterwards. But it's been a wonderful adventure and wonderful adventure of discovery to see the complications that can occur and learning from our colleagues and friends of how best to deal with the complications. So that's the end of my talk. Thank you.
Thank you very much for a very interesting lecture, Professor Ruthman. Very nice management of complications. I just want to ask 2 questions. I thought that in these kind of complicated cases, I myself prefer to perform the DSEC over DMEC. I think for cases with aphakia and these complicated cases, maybe DSEC is preferable. I want to ask you in which cases you perform DSEC, and if you do DSEC in any case, or you perform DMEC for all your cases who need endothelial keratoplasty. Thank you, Professor.
Yeah, that's an excellent question. I think when I first was introduced to DMEC, when I first started doing it, was about a decade ago. I went to see Dr. Mellis again in 2011, and I started around the same time to do DMEC. Prior to that, I was doing DSEC and was reasonably happy with the outcomes. But once I started doing DMEC, I got probably overly excited about the procedure. I mean, it's just so elegant, and it replaces only the tissue that's damaged. And I sort of made it my goal to try and eliminate DSEC from my vocabulary altogether. And the truth is that I don't think there wasn't really data out there to show which cases are going to be good and which cases are going to be bad for DMEC, and my goal was to try and develop or modify techniques such that I could use them in the more complicated cases, like post-vitrectomy, patients who've had trabeculectomies or have glaucoma devices installed in the anterior chamber, post-penetrating keratoplasty, as Jose beautifully illustrated for us. All of these more complicated cases, I just felt like I want to try and push the limits of the technology. You know, that's the nice thing about having fellows, is that they keep you honest. They looked at the data, and so now my view on things is different than it was, say, 5 or 6 years ago. And I think that I think the best cases, the complicated cases, are PK and those that have had glaucoma procedures. If they've had a vitrectomy and there's a lot of iris loss, most of those cases you can still do as a DMEC, but if it's a complex case or they've got aniridia or aphakia, you really don't have a big margin of error to do those cases. So in those cases, I'll definitely go towards an ultra thin DSEC, which our iBank prepares for us quite nicely now, so that we get a good tissue that's very, very thin. So, you know, I'm not 100% DMEC anymore. I wish that I was. That was my goal, but I don't think that it's a realistic goal. I don't think it's necessarily a good one, but it was part of the journey that I'd be interested to hear what your faculty and what Jose and Harminder have to say about it. But you know, it's definitely not the procedure for every single eye.
Thank you, Dr. Uthman. Nice presentation, excellent.
Thanks.
I had the same question. I think you already answered. And I have to mention that the patient that rewarded you, you really realized that you have such challenges. Maybe has realized that you had challenges, so it paid off, and it was a good reward for you because you had, okay. And you partly answered this question. If the patient is aphakic and there is a white pupil, and still you said you may do DSEC, but maybe in most cases you prefer still DMEC. So what measures do you for these cases? Do you do any scaffolding or gliding or something like this, or you go after DSEC in these cases?
So if it's the patient's aphakic and has a large pupil,
and the pupil, yes, and the pupil is wide, you cannot make it down the pupil. And
yeah,
you already mentioned that you may do DSEC, but if you are going to do DMEC in this case, what measures do you imply? For example, do you put any scaffolds, artificial scaffolds, or maybe some gliding or something like this?
I haven't used a glide or a scaffold, but I did use the reverse folding technique that Massimo Busin and Murain have popularized. Doing a pull through, you can grasp the donor and pull it in, and then with a little bit of tapping and maybe just a little bit of fluid infusion, you can open it up. And I've been successful in doing that on a few cases. I've also been unsuccessful where you have one chance. If it's a pull through and it opens up and you get an air bubble, then everything's great. But if you let go even for a millisecond of your forceps, that donor is going to be lost into the vitreous cavity. Okay.
And maybe fixating an IOL would be secure for these cases? Will it support the DMEC in these cases?
Yeah, I've done many cases like that where we've done an IOL exchange, maybe an anterior chamber to a sewn-in posterior chamber lens. And they work out fairly well. It's a lot of work in one case for sure. But I think that's a totally different situation than an aphakic one. If you've got an IOL there and there's reasonable iris cover, then the chance of the DMEC being dislocated into the vitreous is less. What you have to be mindful of is what's going on with the pressure in the eye. So either you put in a posterior infusion, which I generally don't do anymore. What I do is I take the BSS cannula and infuse it behind the iris to fill up the vitreous cavity. And then I'm very mindful of what's happening with the whole globe. If you're pushing a lot and you're tapping a lot, you're losing fluid and the eye is getting slowly compressed. And that those cases are not going to go well. But if you're mindful of keeping the vitreous cavity filled with balanced salt solution, then you can usually manage those IOL exchange cases with the DMEC.
Okay, and in these cases with such a defect in the pupil, they may need the artificial iris as well. And if you suture, for example, a lens into the artificial iris, may be a good option for these cases. Okay, thank you very much. Is there any other question, or we can go ahead with other presentation? Dr. Hashemian?
Just a small question. Do you prefer SF6 or air for the tamponade?
We did a study a number of years ago with one of our fellows, and we didn't show any difference, but it could have been that our sample size was too small. Generally, I don't use air on a regular I don't use SF6 on a regular basis. If it's a very complex case, I'll consider it. But generally, if you get a good air fill with a little bit of pressure in it, then I think air is quite adequate.
Okay, I think there are some common questions that at the end of the session we can ask from all speakers. One of these questions was this one. We'll ask other speakers to know their opinion. And I think we can go ahead with the program. And the next speaker is Professor Harminder Dua, and it is an honor for me to introduce him. Actually, he needs no introduction since everybody knows him. He is an internationally renowned ophthalmologist, researcher, and scientist. He is the chair and professor of ophthalmology at the University of Nottingham and is the head of Division of Ophthalmology and Visual Sciences. He has published numerous scientific papers and book chapters and has given numerous lectures at the most important international meetings. Today, he will talk about interesting topic of DSEC. And let's know if we can get rid of many challenges that we have DMEC with this technique. Harminder?
Thank you.
Please go ahead with your presentation.
Thank you very much. There you are. I'm the last slide already. We try and get right to the beginning. So, well, it's my pleasure to be part of this meeting with other really renowned international colleagues, Professor Rootman, Jose Guel, and yourself and your colleagues. I'm going to be speaking about predestined endothelial keratoplasty, the thinnest ultra-thin DSEC, its science and the surgery. And these are my declarations of interest. We talked about these procedures, and the question David raised was, which procedure do you prefer? And that question was asked by others. It's all about vision and the quality of vision and how long it lasts. Then it doesn't matter which procedure gives you the best. So we know from DSEC and DSEC, they usually 150 microns, can be thicker, can be a little thinner, but the vision was never 6x6 in the majority of cases. With DMEC, the thickness of the tissue is about 25 microns or less, and we most of the times get 6/6 vision, sometimes better. Now, ultra-thin DSEC, as defined by various people, is tissue grafted less than 130 microns. You can say, well, a tissue of 100 microns or less, and it seems to give you the same kind of vision as DMEC does. The concept is that the thinner, the better. The thinner you go with less stroma, the better is the visual acuity. But it's up to a point below which thinning doesn't really add any significant advantage. At least that's what the literature tends to show. Now, this is how the PDEC originated. We were doing these experiments to determine different types of bubbles in dark. So air is injected in a human cornea. You saw the air escaping from the periphery. A lot of air escapes from the periphery. You create a type 1 bubble, you suck the air out, and you can refine it or cut it out if the bubble is smaller than you expect. And then you can lift off this tissue, which is composed of the descemet membrane endothelium on one side and the predescemet layer on the other. And you can note it doesn't scroll as tightly as the DMEC tissue. And this is an experiment we did with Simon Holland in Canada, where I came over and with his fellow, if you take PDEC tissue, which is the left column, it scrolls to a certain extent. Then from each of these tissues in the left column, if you carefully peel off the predescemet layer from the descemet membrane, this is what results. The DMEC tissue scrolls the most, the predescemet layer scrolls the least. Therefore, most of the scrolling to the PDEC tissue is attributed to the descemet membrane, and the PDEC tissue is actually tamponading the descemet membrane and preventing it from scrolling to its fullest extent. And this is just a statistical, I'm just trying to move this out of the screen. It's a statistical demonstration of the significant difference between most scrolling with the descemets, least with the predescemet layer, and intermediate with the PDEC tissue. So at around that time, there was this very interesting paper from Keith Meek's group in Cardiff to show that there's an increased concentration of elastin fibers in the deepest part of the stroma close to the descemet membrane. And at that time, he referred to it as the so-called predescemet layer. And this was shown by a very elaborate technique called the serial on-phase scanning electron microscopy. So you cut a very thin section of the tissue, you scan it, then do another and scan it. And this an automated machine costs about £500,000. And then you make a 3D reconstruction and the fibers can be identified. We then went on from that to look at the extraction of elastin from the different tissues of the cornea and measure its content. And we were able to show that the PDA, the predescemet layer, had the highest amount of elastin comparable to that in the trabecular meshwork. There was no statistically significant difference, but it was significantly more in the predescemet layer than in the descemet membrane. And of course, the corneal stroma, sclera, etc. Now, when you stain, and this is where it becomes interesting, when you stain the predescemet layer, all green is elastin, and you can see the entire thickness of the predescemet layer has elastin. If you stain the descemet membrane, and this was the first demonstration of this unique anterior distribution of elastin in the descemet membrane, just as a band, which we think corresponds to the banded zone of the descemet membrane, and the rest of it, which is the non-banded zone, does not have that staining. And then what you see as C, the image, is the PDEC tissue, where you have the predescemet layer on the top with the uniform staining, then that band of the descemet membrane and the rest of the descemet membrane, which has least elastin. The same is illustrated in D, where half the tissue has the predescemet layer, the other half doesn't, and it corresponds to the images shown in B and C. If you take whole cornea and you stain it for elastin, again, beautifully the same concept. So the previous were isolated tissues, but here you can see that the interfacial matrix becomes apparent, predescemet layer with dense elastin, anterior band of the descemet membrane, and the descemet membrane. Now, how is this relevant? At that time, all of us depended a lot on the scrolling of the Descemet's membrane with the endothelial cells outside as the key to orientation during surgery. But the question was, why does it do that? Why does it always scroll with the endothelial cells outside? Now, on my screen, my figures are slightly obstructed by these lettering, but I hope in your screen it's clear. What I see is that, let me get here. So A, the figure A is the Descemet's membrane. Now, if you take this Descemet's membrane in a Petri dish with medium, and you add elastase enzyme over time, as you will see in B, and then finally in C, it completely unscrolls by itself. And then do a section of this, you will see the elastin band is completely degraded compared to the control where the elastin band on the anterior surface of the Descemet's is intact, which does not unscroll. So that suggested that this elastin band on the anterior surface of the Descemet's membrane is causing it to scroll by contracting this way, and the cells are on the outside. But there was also another explanation, that is the swollen endothelial cells that are pushing the Descemet's to scroll with the cells outside. So we looked at that as well. So A is with the Descemet's membrane with the cells. With very light treatment with Dispase, we took away all the endothelial cells, and we found it still scrolled exactly with the F mark. You could tell it was scrolling with the endothelial cells outside. So the cells had absolutely no contribution to the scrolling. It was only the elastin band. So this is my crude demonstration of that. So if you imagine the rubber band to be the pre-Descemet's layer to start with, and that's the elasticity. You pull it, it'll come back. And this is what happens in DALK, where you hold it tight. And with my third hand, you can see you can pull it down and it'll come back up. You push it down, and that's what happens in DALK. Now, imagine this is the anterior band of the Descemet's membrane. We put a bit of glue and we stick it on the strip of paper, and then you put it there and you let it dry for a few seconds. And when we release this elastic band, this elasticity will make sure that the paper actually scrolls with the endothelial cell, which is the blue color on the outside. So that is giving you an illustration of how that elastin band on the anterior surface of the Descemet's membrane causes this to happen. So, but it's not there so that we can do DMEC, and our hypothesis is the elastin band is actually wanting the Descemet's membrane to scroll in this direction, and therefore is keeping the Descemet's membrane in very close apposition to the posterior stroma. So there's no physical attachments really, but it's still opposed so that it can continue with its function of keeping the cornea relatively detergest. Now, another thing to note is this bubble of the type 2, where if you inject air, you get the separation of only the Descemet's membrane. And when the Descemet's membrane only separates, this is not PDEC tissue, this becomes DMEC tissue. And you can see the amount of air that is escaping from the periphery as well. And when the air is escaping from the periphery, the intra-tissue pressure is variable. The more the air escapes, the more you have to inject to get a bubble of any kind. And if you inject too much, the bubble will form and burst. So that's another consideration to bear in mind. And one of the things we noted was that the type 2 bubble always starts at the periphery. So we let the type 2 bubble form, but we marked the point where it started. Then we peeled off the Descemet's to examine the stroma underneath. And the short of this is that at the periphery of the stroma, there are about 15 clusters of minute holes or fenestrations on a mean of 20 microns each, distributed randomly across the circumference of the cornea. Now, if you imagine, and this is the high power of a 3 Descemet's layer, which we have in other publications shows becomes the trabecular meshwork at the periphery, as you see here. And if you look at the scanning EM and imagine that the Descemet's membrane is attached along the white line, when you inject air, it will come out from here And this air we know goes into the anterior chamber during DAL. But if the descemetes is attached here and the air escapes anterior to the descemetes, you will get a type 2 bubble, which is only the descemes membrane lifting off. And some people actually use this technique to make DMEC tissue. Now, coming on how this is all relevant to what we're talking about, endothelial keratoplasty and PDEC. So the first thing was getting the proper tissue. These fenestrations have two problems. One, they can lead to a type 2 bubble when you can't do a PDEC, or you need a lot of air which is escaping, and it's not easy to get a type 1 bubble because the pressure in the tissue has to be increased and it can cause it to burst. So we said, why can't we clamp these holes? And that's what we did. We designed, with the help of Yannick and company, a PDEC clamp. So this is how it looks in real life. And if you were to use this, and this is how it would work, you center this, very important that the tissue is centered properly. There is this mark which tells you where the side port is, and then you clamp it tight. You put this bent needle bevel up in this case, and you inject the air in the stroma at any depth, but usually mid-stroma. And what you will notice is not a single bubble of air escapes from anywhere. And because those fenestrations are shut, it's very rare. In fact, it's almost impossible to get a type 2 bubble because the diameter of this ring is about 9 millimeters or just over. You can even insert the needle into the bubble to expand it a bit further. And it almost always gives you a type 1 bubble. So here's, you can see the compression on the periphery, but the stroma is very clear. And then that is the actual extent of the bubble, which collapses a bit when you take the needle out. So the bubble is slightly larger than that continuous ring. Now, there was another technique which Nicholas Pereira invited me to join him in exploring and then publishing a paper. And I call this the four-man substitute, which obviates or removes one element of the two. So it stops you getting a type 2 bubble, but it doesn't always guarantee a type 1 bubble. And what they do is simply you score the descemetes at the periphery, just as you would do to make a DMEC tissue. You just score it at the periphery all around 360 degrees and then inject air. So when you do that, all the air that would have collected under the descemes membrane actually escapes out. And you never get a type 2 bubble. You will always get a type 1 bubble, but you will lose a lot of air. The intra-tissue pressure will be unpredictable, difficult to control, and you won't always get a type 1 bubble, or you may get it suddenly and it might burst. But you can still guarantee that you won't get a type 2 bubble because any air escaping anterior to descemes will come out because you've scored it 360 degrees. Now, the procedure itself is here, and this is in an eye bank eye to show you, again, the technique Professor Rootman showed us, where you can prepare the tissue before insertion with the endothelium inside the roll rather than outside. So the various ways of cutting this, we've used narrow scissors, broad scissors, curved scissors, straight scissors, and we've also used the trephine. With the scissors, you can go right out to the periphery and you can cut it. But incidentally, you probably would be aware that eye banks are now giving you pre-prepared PDEC tissue. So here you can stroke the stroma side if you like, and here you roll it back so the endothelium is inside. And this again, referring to Professor Rootman's observation, which he made of Boussin's technique, where you can pull it through and then hold it in these vitrectomies eyes till it unfolds, and then hold it till you put some air in before you let go. So, but if you let go before, then you can still lose it. But this is PDEC in a patient, and what you're seeing over here is that we're cutting the periphery, we are putting vision blue to stain the edge, then you trephine it all, and you can cut a lot. Is this the same video? Sorry, maybe. Yeah, let's see this one. So yeah, this is in the patient with proper vision blue, not the diluted version. You can load it into a lens cartridge, or you can suck it into a goiter type of pipette, and it'll scroll with the endothelial cells outside. Here we're using a bit of air to open it, but the same tapping techniques. The only difference is it unfolds much easier than DMEC tissue, and it's easy to manipulate inside the eye. And because the amount of tissue endothelial cell loss relates to the amount of manipulation and time spent in unfolding it in the eye, this has an advantage because it doesn't take that much. And there were various techniques. This is Amar Agarwal's first technique when we published the first paper on PDEC, with some of the videos which shown you here included in that. We used to take the spring out of a lens cartridge, but these were some of the results. Now you can see we have used donors aged 1, 2, and 4 years old, and many more in that infant age group as well. And these are some of the other examples. You can see immediately post-op and then 2 months later, and there's hardly any difference from DMEC outcomes. Here you can see, just barely see the edge of the PDEC graph. And again, more examples on the OCT, you wouldn't be able to tell whether this is a PDEC or a DMEC graph. And you can see the post-operative outcomes are pretty good. And the visual acuity, again, matches that of DMEC. Again, a few more of those. We tried to compare the endothelial cell loss if you use this method to create PDEC tissue versus DMEC tissue. So if you get a type 2 bubble, which is Descemet's only, is the endothelial cell count of that different by the pneumo dissection approach with the PDEC? And we found there was no difference really. In fact, PDEC tended to have a slightly better trend towards greater endothelial cell density than DMEC tissue. Now, since then, there are many papers, and I'm not going to go through all of them, appearing in the literature, and more people are using the PDEC technique. And like I said, eye banks are providing pre-prepared PDEC technique tissue for transplantation, which will make its use more common. And again, there are some other papers over here. The conclusion with this was that the posterior lamellar keratoplasty, DMEC and PDEC can be performed in phakic eyes. And this was specifically in phakic eyes, which are quite difficult. And the results are pretty similar, and so on. So, like I said, if you can go and look, there are about 40 papers in the literature on PDEC and various aspects of PDEC. But coming back to the main point, which is this, which is also more or less the summary slide, is that DMEC is the gold standard. PDEC would still be classed as innovative, but not as much as it was in the past. With DMEC, we know there is a steep learning curve. The unscrolling can be difficult. The younger the age, the tighter and the thinner is the DMEC tissue, and that's where you run into problems. So most of us prefer older tissue, with all the problems associated with older tissue. PDEC is easier to unroll. Sometimes DMEC can be very difficult to center, and then it rolls again and you unroll and recenter, and then when you inject the air, it slips again, and you get air with the DMEC tissue in a slightly different position than you intended. And that's more with the younger tissue, less with the older tissue. That's not the case with PDEC because the predismissal is always there. And in early cases, when you're starting off the procedure, the endothelial cell loss is less with PDEC than with DMEC. The big difference is the next one. Any age cornea can be suitable for PDEC. And I was speaking to Amar Agarwal the other day, and he was speaking at UCornea when Jose was there. He doesn't use PDEC for any donor more than 35 years old. Now, in India, perhaps they can get that large supply of tissue of that age. But what he has shown very interestingly is no matter how edematous the cornea, more than 1 millimeter thick, really long-standing corneal edema's, and some which have haze in the cornea, which almost looks like scarring in the cornea, they clear dramatically well when we put in young donor tissue, rather than with the standard ones we get about 60 plus on an average. So you can't have DMEC tissue prepared from a 35-year-old donor because it's extremely difficult. It will tear, it will be very thin, and it will scroll very tightly, and you'll have all the problems with it. So I think, and definitely what Amar Agarwal thinks, because he's done more than anybody else in the world, that the future is for PDEC from younger donors, where corneas, which today we might think would need a PK, because of the long-standing edema and the haze, you might be able to salvage with very good vision using PDEC. And what none of us now talk about is the long-term follow-up. These results will come, and we do mention it, but we talk about endothelial cell loss in the first year or second year. But if you look over 5 years or 10 years, you will have much more endothelial cell loss with older donors than you have with the younger donors. And that's where I think PDEC will come into its own. Like I said in the beginning, it's not only the quality of vision, but also the duration for what that quality lasts. The limitation with PDEC is its size. It's very difficult to get an 8-millimeter graph, usually 7 or 6.5. But if you are doing, we're nowadays even doing hemi-DMEC and quarter DMECs, then certainly if you look at the total endothelial cells that you are transplanting, you will have more than what you do with a hemi-DMEC with a PDEC, and definitely you can do a hemi-PDEC. Nobody ever tried that yet, and get more tissues than you get with a quadrant DMEC. So there are lots of positives with the PDEC, but for me, the journey has been that quite apart from the operation, it has taught us so much more about posterior corneal anatomy. We understand so much more about all the dark and endothelial keratoplasty procedures. And now we're going to learn more about how younger endothelial cells contribute towards long-term health of the cornea compared to older endothelial cells. Thank you.
Thank you.
Thank you, Professor Dua, for the very nice and interesting lecture that changed our view about the PDEC. I myself thought that the PDEC cannot have a place in endothelial keratoplasty, when you compare it with DMEC, it seems that there are some very good benefits. I have just 2 questions. Is there any difference in the rejection rate, at least theoretically? And have you ever performed the PDEC after keratoplasty?
Sorry, the first one was rejection rate. What was the second question?
After keratoplasty, do you perform the PDEC after keratoplasty or in other complicated cases?
Yes. So what we know from the biology of the corneal stroma is that the antigen presenting cells, which we call the Langerhans cells or the dendritic cells, are predominantly in the epithelium, which is the Langerhans cells, and the dendritic cells are in the anterior third or maximum anterior half of the cornea. But the deeper you go, the less antigen presenting cells there are. And there are more and more papers now supporting our original contention that the pre-Descemet's layer is acellular, and it may have only the very odd cell. So if it is acellular like the Descemet's membrane, the rejection rate, at least on immunological basis, would be equal to that of DMEC. We have not seen rejection with PDEC, but the numbers worldwide have not been that many. And if you look at the United States, because I was talking to Booson about this, and he said that when they do the comparisons, it's mostly ultra-thin DSEC with DMEC nowadays, but not with PDEC, because The total number in the registry are very few and to give any reasonable comparison. But when the numbers build up, we will have that information. But there's every reason to expect that the rejection will be as low. Now, when it comes to the difficult cases, and this is where David Rootman's view might be important as well, as he showed that, and of course, Jose does a lot of difficult cases, where you wanted to unscroll with the least difficulty, then this is the better approach. Where you want to hold it without risk of tearing a bit off with a forceps, then you have the stroma to grip on and it won't slip. So like in the vitrectomy eyes we saw, and like the other aphakic eyes and so on, that's where PDEC might be better option than DMEC. So I think we have to have an open mind rather than shut it and say, no, PDEC is not going to be there, therefore not think about it. If you start thinking about it, then you will find that there is more it offers than there is to detract from.
Okay, thank you very much, Harminder, for a very excellent talk. Dr. Hashiman, how much time do we have?
I think we have about 20 minutes.
Okay, so I have a question from you, Harminder, and after that, I will raise several small questions, common questions that all speakers, I would like to answer them. And the question about the PDEC, it is an interesting procedure. And as you said, it may be popular in the future, more popular, and may replace the DMEC or not. I'm not sure, but the most problem is that challenges that beginner will encounter a new procedure, because many of them are adapted to DMEC, and we want to switch, and there is a new learning curve, transition period, and people usually are afraid of switching to new techniques when they are adapted to the techniques that they are using already. So what do you recommend for the beginners or for those who want to switch? Do you advocate to switch to this technique or continue with DMEC? I want your recommendation.
Yeah, so we have all had the good fortune of being there with the evolution of doing PK, then doing DSEC with manual DSEC, then doing automated DSEC, and then moving on to DMEC. So most of our skills, the principles are the same. But DMEC was a complete challenge. And the biggest challenge in DMEC are two: preparation of the tissue and unrolling it in the eye. Those are the two major challenges. So if you're going to go from DSEC to DMEC, you have PDEC in the middle, you will be able to teach your juniors much easier because the unscrolling is not that much of a challenge, right? It is little more difficult than ultra-thin DSEC, but definitely easier than DMEC. So it might actually be better to go to PDEC before going to DMEC. But the difficulty is in the preparation of the tissue, because that's where there are lots of uncertainties. And that is why we focused on that at the beginning to try and understand the dynamics of the big bubble formation. We published a lot on it. And the fenestration and the PDEC clamp will be a big help, so that you don't want a type 2 and you don't want to burst your bubble. Because if there is air escaping, you have to attain a certain intra-tissue pressure for the type 1 bubble to form. The more the air is escaping, the less the pressure, you inject more. And if there's no control, suddenly the bubble forms and bursts before you can do anything. And that is very devastating when it happens, because you've lost the tissue. But with the PDEC clamp, and I get no honorarium, I must tell you, although I invented it, I get no honorarium from the manufacturer, not a penny on the PDEC clamp. You can do in a very controlled manner, keep pushing air, keep injecting it, and none is escaping, so all is collecting and the bubble will form. But it'll become even easier if your eye bank gives you pre-prepared PDEC tissue, then that difficulty is out of the way. All you have to do is put it in the eye and make them see how easy it is to unroll.
And
But
can
you
we use, okay, can
So
we
you
use,
still need the F mark or some kind of, if you have an F mark for the beginner, that's always easier.
okay. Can we use our DALK donors for rehearsal of this technique? We will not ruin the cornea, I mean, if you want to use them.
Well, we have looked into that. So if you once you get the PDEC tissue, then you don't have that smoother surface left in what has remained, and it's also full of air.
Mhm.
Okay, so when we do DALK, we only take away the desmids from the donor, which you can use for DMEC. But with PDEC, you will take away the desmids and the pre-desmids layer. So the surface left behind won't be so smooth. And what's left is full of air. But once you put that in culture medium and leave it, and we've noticed after 3, 4, 5 days that the air goes away and it comes back to what it is. So you can still use that tissue for lamellar keratoplasty, but I don't think it will be as good as the tissue we use nowadays for DALK, because the PDL is there with the tissue. But again, if you want to do like for like transplantations, in DMEC we do desmus membrane for desmus membrane. In DALK, we leave the patient's pre-desmus layer behind, and we also bring the donor's pre-desmus layer. You end up with 2 pre-desmus layer in DALK, and you get the type 1 bubble, which is 80% of the times. So if you have a DALK from which you have done a tissue which you've done PDEC already, then you're bringing donor without the pre-desmus layer and the patient's pre-desmus layer there. Then it becomes like for like. That's just theoretical.
Okay, the question, if there is no other question, I will ask several very short questions from all the speakers because they may be useful. Before that, if any,
would you please ask? Yes, I wanted to
Okay.
ask Professor Ruth.
and after that, if any of the speakers have any comments, we will hear from this. So the first question is that, do you mark the cornea? Dr. Ruthman said that he started to mark. He didn't run. He used not to mark before, but he started to use mark. Dr. Guel, do you mark the cornea?
Always. I
You always-
always mark. I put the F mark. You can put an S mark. But
Okay.
the thing is that, you know, even if you're the best surgeon, you will get it wrong sometimes.
Okay.
And so many of them have got it wrong. And they have presented videos in meetings when they thought it was right, and only the F or the S told them it was wrong, and then they reversed it. So even if you can save one eye, it's worth it.
Okay. Dr. Guel, how about you?
Well, I understand Harminder's point and many other colleagues' points, but I must recognize that I do not mark. I think, for example, in the video of David was very demonstrative. I think if you evaluate without so the positioning of the roll without touching the roll, it might very well confuse you, because it's very, especially in very opaque corneas, it's very difficult to see just touching from the outside if the fold of the periphery is downside or upside. So, but if you have a cannula inside the eye, it's impossible not to distinguish it. So, well, that's what I think, and respecting completely Harminder's final statement, I never mark.
Okay, but even for the beginners, I think I recommend for the beginners to mark at first, because the more experienced surgeons, they don't have much problem with the alignment. But I think the beginners, it's better to mark. It's my own recommendation.
That's exactly what when we teach years ago LASIK. In the beginning of LASIK, we used to mark the cornea, and I think that is still a good strategy for beginners.
Okay, Dr. Ruthman is not here because I think he already answered the question. Are you here?
I'm here. Yeah.
Okay, sorry. Do you
That's
have any
okay.
comments on that? You already mentioned that nowadays you use.
Well, I did notice Jose's little modification there of having a cannula inside the eye. I haven't tried that, and it's really a nice little hack that he's showing us that I think can help obviate the problem. I do think it kills cells, because I do remember my first few cases, the cornea seemed to clear much faster. I did at least my first 50 or so without marking, but I did have some unexplained failures in very routine cases. So I do think there is some damage from marking. So that's why we've gone to sort of what I call a minimalist F. I used to make a full F, like a one line down this way and then two going this way. Well, the other way.
This is also kill the cells. This will kill
Pardon?
the cells. This
It
will
kills
also
the cells.
No, I mean
Yeah.
this technique also will kill the cells.
It will, yeah, for sure. The F mark will. So
No, I mean
But-
the technique that you remove some part of the donor. It also
I don't-
kills the cells. It does. Okay.
I don't remove the don't. I'm not sure what your question is. Sorry.
Okay. Let's go ahead.
Professor,
Can I make a comment here? You know,
Oh, yes, please.
no matter what we do, so there are people who don't put an F mark, but they do a small trephination of the edge and a big trephination, you know, like Frederick Cruz has described, to take two. Each of them, you're losing some endothelial
You're
cells.
losing cells.
And
Yeah.
Yes, I was the same question from you.
Yeah.
The same question,
So
okay.
but people have tried various ways to mark just for, you know, some people climb up the mountain with the bare hand and no ropes, and some people have ropes. So it's just that added kind of security. But I think it's horses for courses. One should not forget that we have patients waiting for a year, sometimes more, before they get their cornea transplant appointment. And the cornea becomes very hazy. And when I see the American surgeons, it's almost like, why did they do a DMEC? The cornea was so clear. I mean, it looks like that. Because the duration of the edema will make the view so difficult. Sometimes even we have to put more membrane blue or vision blue in the AC to restain to see the graph, because it is so hazy to look at it. So in those cases, the F mark really comes to your rescue. If your cases are all very early Fuchs dystrophy cases, the visibility is so good, you can see the orientation and all that. And also what I found was that with the F mark also, you cannot see the F mark so clearly when the tissue is in the anterior chamber, unless you push it against the back of the cornea with the air. And then it becomes visible. Only then you realize it's the wrong way or the right way. And while you're doing it inside, it's not so easy to. So there are limitations even of marking. But like I said, I always know.
But my question is that usually the people do marking on the desmet side, not on the tilium. So why does it kill the cells? Because you put on
Because it penetrates. It has some sort of solvent that penetrates through desmase membrane. Is very, very aqueous soluble. So it's going to penetrate through. So I've noticed, just to get back to my point, is that I always make, now instead of making an F, I make a line, a vertical line, and then a dot. Sorry, it should be on the other side here, because I make a dot here. So I call it a minimalist F. So I'm trying to reduce the amount of ink that I'm using on the surface. The other thing is always make your mark the same way. So the spine is a radial line, and it's close to the edge, not to the center, because I've seen some people that make the mark in the center and then they end up with edema right in the center. It's a little bit of edema on the periphery you can handle. In the center, obviously, it causes more difficulty. So always make your mark the same way, because once it's in the eye and you're under pressure, it's sometimes the first thing to go is your right-left orientation. At least that's my experience. And so I like to I stress to the fellows, always make the line and the dot in the same place, so that no matter which way it goes, you'll have less difficulty orienting and being certain. And since doing that, I think we've had very few unexplained failures. Of course, we've still had failures, but we at least have an explanation, and I sleep much better.
And another question starting from you, what's your preferred injecting device?
We've been using the Gouter tube now for at least, I don't know, 6 or 7 years, and it's quite a nice device. And the nice thing about it is it's transparent. But I must say, I must admit that I miss the homemade injectors that I used to use, made out of an IOL injector tube.
Okay.
You know, either the Alcon one or one of the other companies. It doesn't really matter. You can just attach it to a tube. But in many ways, I think you control the scroll better with those kind of injectors, as I saw both Harminder and Jose doing, and I was getting very nostalgic that I'm not doing that very much.
Okay, thank you. And Jose, what do you use?
Unmute.
Unmute, we cannot hear you.
Excuse me.
Okay, yeah.
As most of us, I've been throughout these last 15, 16 years in the neck with different instruments.
Okay.
But for the last, I would say 8, 9 years, I am using a modified Medicel injector, which is under my name. And the only, let's say, small difference that it has is the standard intraocular lens injector, but once you close it and you fix it, you can use this finger, your index, to move a small wheel, and you slowly introduce the lenticle inside the eye, because I very much like precision on that, and I do not like to use my thumb. I like to use my index. So it's a standard IOL injector from Medicel, which has a very low surface tension, the plastic that they use, and you have never the problems of a connection between the lenticle and the carotid. But also with this tool of the wheel, you can inject it very slowly and controlling.
Okay, and Harminder, how about you?
So we've switched to the goiter pipette, the glass pipette, in the last maybe 3-4 years. It is very expensive, at least in the UK, and it adds to the cost. And the cartridge used to cost nothing, that costs more, but it is so much easier. One of the big problems with injectors, if you get even a little bit of air, it causes a lot of problems. And even a tiny bit of air in the AC when you're trying to unfold, as we know, is not good. So with the goiter pipette, because it's all underwater, you can completely avoid any air. But one interesting point I heard Professor Rootman say about the bevel. Now, what I do is when I look at the scroll, and if the scroll is like a cigar, then you suck it back and forth a bit and it'll open. And if it is a double scroll like the one you want, then I will see the orientation in the glass pipette, and the bevel then goes in such that that scroll is up. So if you rotate, it doesn't always rotate. The tissue doesn't always rotate in the pipette. But if I see that it's like this, I will rotate it so that this is up, and no matter which direction the bevel is, as long as I'm putting my tissue in with both the scrolls facing anteriorly. That's the only difference. And it served us well, this glass pipette.
Okay, thank you. I myself prefer the modified Jones tube, which was developed by Stryko. It is like goiter, but it is much cheaper. But I am not sure it is available. I got some from Stryko himself, but it's very cheap. Goiter is very good, but it's expensive. And Dork also has one. It's very long. It's difficult to use. And my last question is about ROCK inhibitors. There was not anything about that talked in the talks, because it is usually used in endothelial implantations like cell implantation or DVEC. But is there any role in your DMEC practice or DVEC practice in your practice? And I mean, please start from you.
About what?
ROCK inhibitors. Is there
ROCK inhibitors.
any
No.
place in your practice?
No, none at
No.
all. We don't use them at all. But I think the bigger question you're alluding to is, we talked about surgery, but what is the post-op management? Because what do we use? How much steroids? How much antibiotics? I heard Jose say they put intracameral cefuroxime, which is interesting, but I've never done that following endothelial keratoplasty procedure, but I might try that if he has had no problems. And when do you check the pressure? When do you release air? How long do you position the patient for? And if you see detachment immediately post-op, like in 4 hours or 3 hours later at the periphery, do you rebubble then? Do you wait? I mean, all these are very important questions which determine the final outcome, and how much steroid, which steroid, how long, all those kind of things. So there's a lot more to endothelial keratoplasty than just the technique.
Okay, yes. Unfortunately, we did not have time to cover the postoperative care. And Dr. Goel, the same question from you: is there any place, for ROCK inhibitors in your practice? You are. Please unmute.
Unmute the phone.
Excuse me again. This is a double response, so regularly not.
Not okay.
But I am involved in the COVA study, European study. So we have been for the last 3 years, including patients, doing Decimet stripping only. And this is a double-blind study, so obviously I don't know who of all those cases are with ROCK inhibitor or who are with simply tears. So we are under the evaluation protocol. So let's see.
For DVEC.
For
Yes.
DVEC, yes. This is the COVA study. Yes.
Okay. Unfortunately, we didn't. Okay.
Just a brief comment regarding the cefuroxime injection, Harminder. You can see in my videos, I do not inject the same amount of cefuroxime that I'm injecting in my standard full thickness keratoplasty or cataract surgeries. Just a little bit, but I use the remaining injection to close, to hydrate the incisions. So it's a kind of way to reduce toxicity over the lenticle, but to feel better going to sleep, having injected some antibiotic.
Thank you very much, Dr. Hashemian. I don't think you have time to go ahead. But
if any comments we have from our dear guests, I should thank our dear guests to help us have such an instructive meeting. We invite you all to come to our country, to Iran, to see you in person, maybe in near future. I should thank Professor Qureshi for his help to hold this webinar, and I should thank Professor Nasser Hashemian, head of cornea department, for his great help. And finally, I should ask my dear friend, Mr. Omidvar, can you open your cam? He helped me very much in preparing the meeting. We sincerely ask all your guests to be in our future webinars and come in person to see our country. Thank you very much.
thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Goodbye.
Have a good evening.
You too.